It happens to so many of us, right? You know, you walk into a room and just pause, thinking, why am I here again?
Oh, absolutely.
Or you're looking for your phone and it's been in your hand the whole time. These little glitches, they can feel more common as we get older.
Yeah.
And it naturally makes you think a bit more about memory, about your thinking.
Sure does.
Now, add a major health challenge into the mix, something like cancer, and suddenly those concerns about cognitive function can feel really significant.
They absolutely can. It becomes this extra layer of worry, on top of everything else that's going on. And it's complicated because, like you said, just aging itself brings cognitive changes.
Right.
So when you put that together with cancer and then the effects of the treatments, well, the picture gets pretty complex.
Which is exactly why we wanted to do this deep dive today. We're looking right at that intersection. Cognitive function in older adults who have cancer. Our source material for this is it's a really thorough expert review, published in a good journal, pulls together a lot of research to try and give us a clear view of what we know now.
Yeah, and our mission really is to take all that dense information and kind of cut through the complexity.
Okay.
We want to understand what's actually happening to cognition when cancer and aging meet, how doctors assess these changes in the clinic, what the current thinking is on managing them, and also, really importantly, where the research still needs to go. It's about getting you those key insights so you feel well-informed.
Okay, great. Let's unpack this then. So the review kicks off with a pretty foundational point. Cancer is, by and large, a disease linked to aging.
Right.
Most people diagnosed are 65 or older.
That's such a critical starting point. And what's really fascinating, or maybe concerning, is that the cancer itself, and maybe even more so the therapies used, they don't just target the tumor. They can actually speed up certain aspects of aging throughout the body. And that includes the brain and how it functions.
Wow, so it's not just two separate things happening side by side. They actually influence each other, potentially accelerating cognitive changes.
Exactly.
And this is where that term CRCD comes in. Cancer-related cognitive decline.
That's the one. CRCD is basically the umbrella term for those changes in cognitive function. Things like memory, attention, executive functions like planning or problem solving, and processing speed, how quickly you think. Changes that happen after a cancer diagnosis or treatment.
And the review mentions that even though these changes might be more subtle than, say, dementia, they still really hit quality of life. They affect how people manage their daily routines, and they can stick around for months, maybe even years.
Oh yeah, they're definitely not trivial. Now, the source also brings up another really key point. Older adults often come into a cancer diagnosis already having some cognitive issues.
Oh, right.
The review cites data showing that a noticeable chunk, somewhere between about 4% and 7% of adults 65 plus with cancer already have dementia beforehand. And if you look broader at the general population over 70, estimates are around 14% with dementia and another 22% or so with what's called mild cognitive impairment, or MCI.
Those numbers really paint a picture, don't they? A lot of people are starting this cancer journey with some existing cognitive vulnerability.
Precisely. And the tricky part is that the stress of the cancer diagnosis, the treatments themselves, they can sometimes unmask these underlying conditions or make them worse. So it raises this really important question for doctors and researchers. How do you tease apart what's just typical aging, what's a pre-existing issue getting worse, and what's specifically being caused by the cancer or the treatment?
Yeah, that sounds incredibly difficult to figure out for any single person. So how do experts even start trying to identify who might be most at risk for these cognitive changes?
Well, the review is pretty clear that the absolute starting point is getting a really detailed patient history.
Okay.
Talking to the patient, often talking to their family too, that's crucial for spotting potential risk factors early on.
Right, makes sense. So what kinds of things are they looking for in that history? This is where it gets really interesting, I think.
Well, age itself is obviously a factor. Chronological age matters.
Sure.
But the source points out, and this is key, that aging isn't uniform. Cognitive aging varies a lot from person to person.
Right, everyone ages differently.
Exactly. But what's notable here is that some cancer treatments, especially chemotherapy, can actually bring about brain changes that look quite similar to age-related changes.
How so?
Things like reductions in gray matter volume in certain brain areas, or changes in the white matter, the connections. Treatments can mimic that.
Huh. So age is a risk, but the way treatment affects the brain can actually look like accelerated aging in some ways.
That's a good way to put it.
Okay, what else puts someone at higher risk?
Low cognitive reserve. That's a big one.
Cognitive reserve. Explain that a bit.
Yeah, so the source defines it as your brain's sort of innate or acquired capacity, its resilience. Think of it as how well your brain can cope with damage or changes and still function okay.
Like having a mental buffer, maybe, build up over time.
Exactly like that. Things like having higher education, a mentally demanding job, staying involved in stimulating activities, being physically active. All these things seem to help build that reserve.
Okay.
And the review clearly states that having lower reserve is a significant risk factor for developing CRCD.
That makes intuitive sense, yeah. A more robust brain network might withstand the hit better.
Then there are other health conditions, comorbidities, and especially frailty.
Frailty. We hear that term more now regarding older adults. What does it signify here?
So the source describes frailty as more than just being weak. It's like a systemic loss of reserve across the whole body.
Okay.
It means someone has a reduced ability to bounce back from stressors, and cancer treatment is a major stressor.
Right.
Patients who are identified as frail, or even pre-frail, before they start therapy, seem to be the most vulnerable to cognitive decline from that therapy.
So it's really about the person's overall health and resilience, not just the cancer or the treatment in isolation.
Exactly. It's the whole picture. The review also mentions psychological factors and symptom clusters.
Like what?
Things like high levels of distress, anxiety, depression, maybe a history of trauma, or having clusters of symptoms like ongoing fatigue and really poor sleep. These can also increase the risk for CRCD.
It sounds like such a complex interplay between the mind, the body, the person's history.
It really is.
What about on a more sort of biological level? Are researchers looking at specific markers?
They are. The review talks about host biology, noting it's definitely a research frontier right now.
Okay.
They're investigating various biological markers. Genetics is one area they mention, the APOE4 allele. That's the one known to increase Alzheimer's risk.
Right.
And some studies suggest it might also be linked to worse executive function in older adults getting chemo.
So our individual genetic blueprint could play a part in our vulnerability.
It seems possible, yeah. They're also looking at markers of what's called biologic age.
Biologic age, as opposed to just years lived.
Exactly. It's about how old your cells and tissues seem to be functioning, which might not match your birthday.
Interesting.
The source mentions markers like P16, which is sometimes seen as a sign of cellular wear and tear, senescence. Some research shows it increases with chemo, suggesting maybe an accelerated molecular aging process.
That connects right back to what you said earlier about treatments speeding up aging.
Precisely. And inflammation markers are another area. Things like IL-6, TNF-alpha, these have been pretty consistently linked to CRCD in various studies.
Okay.
But the review is careful here. It emphasizes that a lot of this host biology research, especially with these specific markers, is still kind of investigational. And it hasn't been studied extensively specifically in older adults getting cancer treatment yet.
So promising leads, but needs more work in this specific group.
Definitely.
Beyond blood tests or genetic markers, can doctors actually see changes in the brain that line up with these cognitive problems?
Yes, and that's where neuroimaging like MRI scans comes in. The source notes that changes they can see in brain structure or how the brain is functioning on these scans do correlate with people doing worse on cognitive tests.
What kind of changes?
For example, in older adults who've had chemotherapy, studies have found reductions in gray matter volume in important areas and also changes in the white matter, the brain's wiring, essentially. And these changes are associated with lower cognitive scores.
So you can actually see some physical evidence in the brain that matches the cognitive difficulties people report. That's a lot to consider just for understanding who's at risk.
It really highlights why figuring this out isn't simple and why actually assessing cognitive function becomes so important, which, leads us right into how clinicians try to do that assessment.
And the source mentioned earlier that these cognitive issues often get missed, or maybe patients don't report them.
They do get missed, partly because, patients are understandably focused on the cancer itself, the treatment. And sometimes the changes are subtle, they creep up. That's why there are national guidelines now recommending screening all older adults with cancer before they even start treatment.
Before treatment, okay.
Yeah, it's seen as really critical information to help guide the whole care plan, make informed decisions together.
What kind of screening tools are typically used in a busy clinic setting?
The review suggests using brief, practical tools. Things like the Mini-Conc, the MOCACA, that's the Montreal Cognitive Assessment, or the Blessed Orientation Memory Concentration Test, they're relatively quick screens.
And they help flag people who might need a closer look.
Exactly. They help identify patients who might benefit from a more in-depth evaluation. And the review notes something quite striking. Somewhere between 15% and almost half of older adults show an abnormal score on these screens before they even start cancer treatment.
Wow, up to half potentially starting out with some flags already raised. That's huge.
It really underscores the scale of this, yeah. But there's a caveat the source mentions. These tools, they were mostly designed originally to screen for dementia.
Ah, right.
So they might not always be sensitive enough to pick up the subtler changes that are more characteristic of CRCD.
Okay, so they're a useful first step, but maybe not perfectly tailored for spotting these specific cancer-related cognitive shifts.
Potentially, yeah.
Are there other ways clinicians try to capture those more subtle issues then?
Absolutely. Patient self-report questionnaires can be really valuable here.
So asking the patient directly about their experience.
Exactly. Tools like the FACT-ECOG or PROMIS cognitive function scales or the ERTC one, they let patients report on how they feel their memory or concentration is doing in everyday life.
That makes sense. The patient often knows best when something feels off.
They often do. And these questionnaires have established cutoff points, thresholds, that can signal, okay, this person probably needs a more formal assessment.
Okay. But you mentioned earlier, screening doesn't always happen.
Right. And the review acknowledges this as a major practical hurdle. Despite the recommendations, this kind of cognitive screening is still pretty underutilized in day-to-day oncology care.
Why is that?
Often it just boils down to lack of time, lack of resources in really busy clinics.
Yeah, I can see that being a real barrier. Does the source offer any solutions?
It suggests some practical ideas, like maybe training other clinic staff nurses, medical assistants to administer the brief screening tools, or relying more on those patient self-report questionnaires, which patients could potentially fill out while they're waiting.
Okay, finding ways to integrate it.
Yeah. And crucially, if concerns do come up, whether from the history, the screening, or the questionnaire, the review really stresses that clinicians should refer patients on. Send them to neuropsychology or other specialty services for that deeper dive evaluation.
Right. So, moving on, once treatment actually starts, how does cognition tend to fare? Does the source get into the effects of specific cancer therapies?
It does, yeah.
Yeah.
And it emphasizes that monitoring cognition during treatment and after treatment is really important, using both patient reports and those objective performance tests.
Okay, let's talk about chemotherapy first. That's probably the one most people associate with cognitive side effects, that term chemobrain.
Right, chemobrain or chemofog. The source presents findings, and it shows cognitive changes happen in a pretty wide range of patients after chemo, maybe 10% in some studies, up to over 50% in others.
That's a big range.
It is. Depends on the study, the chemo, the patient group. But one large study found that patients getting chemo were about 4 times more likely to report that their cognition had worsened compared to similar patients who didn't get chemo.
4 times more likely to feel it themselves. That's a really significant difference in perception.
It really is. And objective testing backs this up too. It shows declines, particularly in memory, attention, executive function, that can last for up to 6 months after chemotherapy ends. Now, the review does note that the magnitude of these declines is generally subtle compared to something like Alzheimer's.
Okay.
But even subtle changes can still have a real negative impact on quality of life.
Definitely. What about longer term? Does it eventually go away after chemo?
Well, the evidence there seems a bit mixed, according to the review. Some studies suggest things improve over time, maybe people recover. Others show persistent changes lasting months, even years later, at least in a subgroup of patients.
Okay.
And the source specifically highlights that in older patients, that worsening of cognition over time after chemo seemed to be linked with increases in frailty.
Ah, there's that frailty connection again.
Yeah, reinforcing that link we talked about earlier. Keeps popping up.
What about other kinds of cancer treatments? Not just chemo, but maybe hormone therapies or the newer immunotherapies?
Good question. The review looks at non-chemo agents too.
Yeah.
Starting with endocrine therapies like hormone blockers used commonly for breast cancer or prostate cancer in older adults. The studies there have shown kind of mixed results. Some research finds effects on things like executive function, working memory, concentration. Others don't find significant cognitive changes compared to controls.
So mixed findings. suggests maybe it's subtle or depends on the specific drug or the person?
This could be it. It's not as clear-cut, perhaps, as with some chemotherapy data. However, one finding that does stand out
Yeah.
is about androgen deprivation therapy, ADT, which is used for prostate cancer.
Yeah.
That has been associated in some large studies with about a 21% increased risk of developing dementia later on.
Wow, a 21% increased risk of dementia linked to ADT? That's pretty striking.
It's a notable finding from the literature, yeah. Definitely something clinicians and patients need to be aware of.
Absolutely. What about the really new stuff, like immunotherapies?
Right, so the source notes that some of these newer therapies might contribute to CRCD, but the data is still emerging. It specifically calls out CRT cell therapy.
Okay, that's a very powerful, newer treatment.
Extremely powerful. And it's frequently associated with neurotoxicity, meaning side effects affecting the nervous system. Happens in over 40% of patients.
Over 40%?
Yeah. And within that neurotoxicity, cognitive disorders are listed as common symptoms. Things like confusion, attention problems, language difficulties.
Okay.
But again, the source adds an important caution. Most of the studies looking at CRT neurotoxicity and cognition have primarily involved younger patients.
Ah, okay.
So we still need more research to really understand the cognitive effects, specifically in older adults receiving these cutting-edge therapies.
Right, the population we're focusing on today. Okay, so we've got this picture forming. Who's at risk, how treatments might impact cognition, the challenges in assessment. How are experts actually supposed to manage these concerns when they come up in older patients with cancer?
Well, the review really emphasizes that this is a growing need. With the population aging, we're just going to see more and more older patients who are either at risk for cognitive issues or who already have them when they start cancer treatment.
It's becoming unavoidable, really, as part of comprehensive cancer care for many.
It really is. And one critical piece of management is using that cognitive assessment we talked about to help figure out a patient's capacity for making decisions.
Decisions about their treatment.
Exactly. Cancer treatment options can be incredibly complex. Understanding someone's cognitive baseline helps the clinical team tailor not just the treatment itself, but also the level of support that person might need.
And the source seemed to really hammer home that this isn't just about making the initial decision. Cognitive status seems tied directly to how well the treatment actually goes, doesn't it?
Yes, this is so important. The review points out that having worse scores on those cognitive screens before treatment even starts is linked to worse outcomes down the line.
What kind of outcomes?
Things like a higher risk of experiencing significant chemotherapy toxicity, side effects, and even, disturbingly, worse overall survival.
Worse survival linked to pre-treatment cognitive scores? That's a really critical connection. It's not just about feeling a bit foggy then. It can actually impact the success of the cancer treatment.
It appears so. Because, think about it, cognitive impairment can make it much harder for patients to manage complicated medication schedules, remember all their appointments, fully understand instructions, and maybe most importantly, accurately recognize and report side effects when they happen.
Right, which is crucial for safety.
Absolutely. So this means providing enough medical and social support is vital for these patients. The review stresses how important it is to formally designate a healthcare proxy, someone who can help with decisions if needed, and also to monitor the burden on caregivers, because looking after someone with cognitive challenges on top of cancer is incredibly demanding.
So managing cognition is really integral to managing the cancer safely and effectively. What about interventions aimed specifically at helping cognition itself, during or after treatment?
Right, so for cognitive concerns that do arise, the review discusses approaches often found within survivorship care plans. Sometimes referral to specialists like neuropsychologists or maybe integrative oncology services can be part of that.
Are there specific types of interventions that seem to hold promise?
The main areas getting investigated, according to the source, are behavioral interventions. Two big categories here. Cognitive rehabilitation.
What does that involve?
It can include things like strategy training, teaching people ways to compensate for memory or attention issues, education about cognition, or sometimes computer-based brain training exercises.
Okay, cognitive rehab. What's the other category?
Physical activity and exercise programs.
Interesting. And does the research show that these behavioral approaches actually help with CRCD?
Well, there's some positive evidence. A systematic review mentioned in the source found that overall cognitive rehabilitation interventions did lead to improvements in at least one objective cognitive measure in the studies they looked at.
Okay, that's promising.
And for physical activity, studies have also shown improvements in how patients perceive their cognition, their self-reported function, and sometimes improvements on objective tests, too.
Good. But is there a catch?
Well, the big caveat, which the review points out repeatedly, is that most of these intervention studies, for both cognitive rehab and exercise, they were done primarily in younger cancer survivors.
Ah, okay. So the direct evidence for how well they work specifically in older adults, the group most at risk, is still not as strong.
That's basically it. The evidence base is thinner for older adults. But the review suggests that for older adults who are perhaps at greater risk of losing functional independence if their cognition declines significantly,
Right.
intervening earlier might be particularly important. Maybe even starting cognitive or exercise programs alongside their cancer therapy, not just waiting until afterwards.
That makes a lot of sense. Trying to preserve function, maybe build resilience while they're going through treatment, rather than just trying to fix problems later.
Exactly. The idea is to potentially preserve function and independence better in the long run for this group.
Okay, that covers behavioral strategies. What about medications? Are there any drugs that can help with chemobrain or other CRCD?
The review is pretty definitive on this point. Currently, there are no established pharmacologic interventions specifically approved or proven effective for CRCD.
None at all.
None established. Now, some drugs have been studied, things like methylphenidate, which is used for ADHD, or modafinil for wakefulness, even donepezil, which is used for Alzheimer's.
Right.
They've been looked at in small studies in cancer patients. But the research is limited, the results have been really mixed, and they haven't clearly confirmed a benefit for CRCD across the board.
So no magic pill to reverse or prevent cognitive issues from cancer treatment right now?
Not yet, no. And crucially, the source makes another vital point.
Yeah.
Dedicated studies testing these or other drugs specifically in older adults with CRCD basically haven't been done.
That seems like a huge gap, given everything we've discussed about older adults being most affected.
It's a major knowledge gap, absolutely.
So speaking of those gaps, the review finishes by outlining where research really needs to focus next, doesn't it?
Yes, it pulls together the key priorities for moving the field forward. A massive one is simply increasing the representation of older adults in CRCD research.
Getting them included in studies.
Yes, especially older adults who might already have some cognitive impairment before cancer. Right now, they're often underrepresented or sometimes actively excluded from clinical trials and studies.
So the studies need to actually focus on the population that's most relevant and most vulnerable here.
Precisely. Another key area is advancing how we assess and screen cognitive function, specifically in older adults with cancer.
Improving the tools.
Improving the tools, yes, but also getting clinics to actually implement the screening consistently.
Right.
And beyond that, adding measures of functional cognition.
Functional cognition. What does that mean exactly?
It means assessing how cognitive changes actually impact someone's ability to do everyday tasks.
Like real-world impact.
Yeah, exactly. Looking at things called instrumental activities of daily living, or IADLs. Can they still manage their medications independently? Pay their bills, cook a meal, use transportation? Measures that really capture the practical effect on someone's ability to live independently.
That seems absolutely vital. It's not just about a score on a test, it's about how it affects their actual life.
Couldn't agree more. And then finally, a major priority is developing and testing interventions, behavioral, maybe eventually pharmacologic, that are specifically tailored for older adults with CRCD.
Not just assuming what works for younger people will work for them.
Right. And these tailored interventions need to be evaluated properly, using not just the traditional cognitive tests, but also those crucial functional and independence measures we just talked about.
Okay.
And the review circles back again to that idea of maybe intervening earlier, potentially starting interventions concurrently with cancer therapy, especially for older adults.
Okay, so if we try to pull back and summarize this whole deep dive, it seems really clear that cognition, cancer, and aging are complexly linked.
Deeply linked, yeah.
And this cancer-related cognitive decline, CRCD, it's a very real and significant concern for older patients.
Yeah.
Getting that baseline cognitive evaluation before treatment, understanding the individual risk factors, those seem like critical starting points.
Absolutely critical. And while there are promising interventions out there, especially the behavioral ones like cognitive rehab and exercise, the evidence specifically for older adults really needs to be strengthened through more focused research.
Right.
And currently, no proven drug treatments exist, and dedicated studies for this specific vulnerable population are urgently needed.
So why does all this matter to you listening to us now? I think the review makes it incredibly clear. For older adults who are facing a cancer diagnosis, trying to maintain cognitive function, trying to stay independent, that's a huge concern. It ranks right up there alongside wanting the best possible cancer outcome.
They often go hand in hand as patient priorities.
And experts, clinicians, researchers, they're actively working towards achieving both. Trying to personalize care, to balance getting effective cancer treatment with preserving cognitive health and daily function as much as possible.
It really is about treating the whole person, considering all their goals and priorities, not just focusing narrowly on the disease itself.
Which leads us to a final thought, maybe something for you to mull over. Considering all these links, the source highlights between things like frailty, other health conditions you might have, the cognitive reserve you've built up over your lifetime, and then the risk of CRCD if you face cancer. It raises a really interesting question, doesn't it? Beyond the specific cancer treatment choices, how much could proactively managing your overall health throughout life, things like staying physically active, keeping other chronic conditions like diabetes or heart disease well controlled, consistently engaging your brain with stimulating activities, how much could that potentially act as a buffer? Could it help protect against severe cognitive impacts later on, especially when facing a major challenge like cancer?
It's a really powerful question about prevention and resilience, isn't it? Something definitely worth thinking about.